I want to know what anatomy means, where this problem is locating, anatomical location. Is it a mediastinal, or is it a lung parenchyma, or is it a pleura? I want to know the type of lesion. Is it an inflammatory, infectious, non-inflammatory, malignant, vascular? These are four major causes of any radio-opaque or radiolucent shadow on X-ray. And of course, I want to know judge the progression. Is a resolution is happening or is it persisting, right? Second, which modality is the best modality to proceed? And what we already know for so many years, even an MBBS student knows, X-ray chest is best for the screening, right? Most of the time we go for the X-ray, 99.9% of time. CT chest is gold standard, it has got best resolution. Though ultrasound is an upcoming, it is best for characterizing the type of pleural effusion. This we already know, everybody knows that this is the basic everybody carries with. Now we'll start with the case and we'll try to learn based on the various cases. This is a recent case who came to my OPD, a 4-year-old. Most of my cases will be OPD based because we pulmonologists, we feel that it is an OPD based practice, 99%. This is a 4-year-old male who presented with onset of swelling for past 6 months whenever patient cries with cough, and off and on patient also had cough. So if look at patient is trying to shout, so some swelling is appear like this one, and you can hear some sound is coming. So he's a very frank and jovial boy, his sound used to reverberate. At this time, I put the same question with me. Should I go for the X-ray chest? Fortunately, patient was carrying X-ray chest in this case. Should I directly ask the patient for CT with lower neck, CT chest with the lower neck? Because I felt that something is emerging from the chest, that is mediastinum. Or should I go for the ultrasound? Ultrasound is easily available, not in an OPD, in ICU, so that is in my hand and that doesn't cost anything. So I took the patient to the ICU and tried to do the ultrasound. As I told you, the child was very cooperative. So I put in probe here and here, and you can yourself can make out. I'll show you what the normal ultrasound neck looks like. If I keep the probe in the midline, if I keep the probe here, you will find the airway like this, and this is the air mucosal interface. This gives you the reverberation. We know that ultrasound rays cannot traverse to the air, so you get these type of reverberation. So this is normal. If I go to the lateral one, you will find these all blood vessel, internal jugular veins, arteries, and sort of thing, right? Now patient is crying or patient is making sound. Look at what difference has been created on the ultrasound. Look at something, a starry sky thing is coming into the way of the ultrasound waves and the airway, right? This is very obvious, even a blind person can understand what is happening. Now, before I discuss this case, let's move back 6 years back. It means it's a 6-year-old child, a male child, who again presented with similar looking swelling, little bit more obvious on the lateral side of the neck. And the same time I did the ultrasound, and in the ultrasound what I found, it was a multicystic swelling that was coming out from the neck. And it was not a classical starry sky. So now we got two cases where the neck swelling is emerging and going back, right? Next imaging again can be MRI. We have done ultrasound, we have seen the ultrasonographic finding. To confirm it, other could be the CT chest and with of course the lower neck. So let's try to discuss the MRI finding in the later case. So in the second case, we got an MRI and we found that there was a huge cyst that was starting from the neck and it is engulfing whole of the mediastinum and middle mediastinum, that is your heart, is engulfed. Actually, it is a thymic cyst, and we all know that thymic cyst starts from it follows the pathway of thymopharyngeal duct. So you can have a typical thymopharyngeal duct, it follows. So this was a case of thymic cyst. Patient was operated. Now we continue with our case number 1. My question in the case, these two cases, what should be the ideal imaging modality? We all know that it is mostly ultrasound, right? The X-ray of the first case showed some mediastinal winding, and to my surprise, there was nothing over, means which was connected to the neck and the thorax. So it looks like something, some problem with the X-ray exposure or some positioning. I got an CT scan, and on CT scan what I could find that this is a sagittal view, and you could find that okay, this is an anterior mediastinal swelling and opacity which is actually entering into the neck. And also you can see this is a classical your classical thymus which we see on a CT scan, and I showed you the ultrasonographic finding. Now, when we talk about ultrasound in the thymus, actually it is a hyperechoic foci. We call it starry sky appearance. This is a typical starry sky appearance from the neck, and this is my patient's starry sky appearance. Also, it has been seen that if your starry sky appearance body that is moving with the cardiac and the respiratory, very likely it is a normal thymus. So there will always be some movement of the thymus, but fortunately or unfortunately, it is emerging in the neck, so we call it cervical thymus. Also in ultrasound, we can identify whether it is a solid or cystic swelling inside the thymic. Is it a mass, or is there some fat is there, some calcification inside? So that is the beauty of ultrasound when we talk about thymus. There is an algorithm for the thymus. If you are suspecting thymic mass on the chest radiograph, also you find the sail sign and wave sign or notch sign, which is very classical. If it is present, that normally indicate it is normal thymus, because we all know that normal thymus cannot suppress or compress any adjoining structure. Like it is a typical family man who get compressed by all the family members, his priorities are last. So it is like a normal thymus. But if that wave or notch sign is absent, you do an ultrasound. If it is a homogeneous, it may be thymic hyperplasia, right? So there are many differences, but today's topic is not about the differentiating thymic masses, it is just what modality we are going to choose. Also, if you are thinking of thymic mass which is evident on chest radiograph, assess the thymic shadow size respect to the age. Okay, if it is increased, you go for the ultrasound and you follow for the thymic hyperplasia, or it is non-hyperplastic. Also on ultrasound, if you find it is a heterogeneous, then the choice of modality is normally CT scan, and it is the best choice for the surgeons because it gives you the best anatomy, especially vascular anatomy, because that is going to be the next step rather than MRI. So MRI contains less radiation, but CT scan is the best choice of modality to delineate. Now look at this child who was inappropriately advised for the MRI or CT scan. It was looking like a normal thymus. A 3-year-old who presented with viral fever, some chest pain, I don't know how much chest pain is actually chest pain in a 3-year-old, and somebody advised for the MRI. Look at the MRI, there are a lot of artifacts you cannot define, and ultimately on CT scan it was a bilobed thymus, that was a normal thymus. A simple ultrasound could have been sufficient in this type of patient, and ultrasound we all know that it is a non-radiating one. Now we talk about lot of radiation, and most of the time we know that MRI and ultrasound are radiation-free modalities, right? Regarding MRI, I'm listening lot of talks for past almost 7 years. The problem with the MRI, which I discussed with my radiologist, they say that it takes lot of time. Now there are new machines, new algorithms. You can do MRI as per the literature. You can do MRI, especially during follow-up of a central mass with atelectasis, with pleural effusion, cystic fibrosis with bronchiectasis, pulmonary embolization. The major problem is that it is a low proton density, especially in the lung, right? And it is susceptible to the artifact because of the air tissue interfaces. Though there are many algorithms, but a simple MRI lung takes 1.5 to 2 hours. So who has got time for that much sedation, that much giving sedation to pediatric age group. So that is a major limitation in MRI. But whenever you find some abnormality in the posterior mediastinum, which is involving probably some part of lung also, mediastinum and the spine, MRI is a choice rather than anterior and the middle mediastinum. Now look at this child who came to me immediately post-COVID era, right? There was very less OPD that time, and it was mainly tuberculosis. So in this patient, as history also suggested, that fever of 1.5 months, loss of weight, rest absolutely fine. Its patient presented with this in an X-ray. On this X-ray, what I could see looks absolutely fine, except some retrosternal area, retrocardiac area, and subcarinal. There is some radio opaque rounded mass I could see here. I don't know whether that is visible there or not, but that is much visible on my screen. Following that, the patient was diagnosed to have a tuberculosis, and by the biopsy, and ultimately ATT was given. Now this mass has actually cleared. So question here in this type of patient, if a patient comes to you, what should be the imaging modality, right? Where parenchyma looks absolutely fine. Is it a CT chest without contrast, CT chest with contrast, or lateral view chest X-ray, right? So these are the three modalities which are in front of us. When we talk about lateral view chest X-ray, normally it gives you a better idea about the retrosternal and retrocardiac clear spaces, which is normally sometimes not visible in the frontal view. So that is the beauty of lateral view chest X-ray. So if we try to define the lateral view X-ray in this patient, we could not find anything extra added information as compared to the frontal view, and everything looks fine. There was nothing like a donut sign, though in the frontal view probably it looks like some subcarinal opacity is there. So you go for a CT chest. When we talk about some inflammation or sub-infection, in general we say that give contrast. I am giving you two CT scan coronal without contrast and with contrast, and look at the contrast between them. This is without contrast, and if you look at the subcarinal or sub area, and you cannot make out whether this mass is lymph node, and especially it's a necrosis or not. But on the B side, look at this subcarinal area. This is definitely necrosis is visible. So one thing is very clear: when we talk about tuberculosis or inflammation, if you give contrast, your necrosis will be well defined. Look at the sagittal plane. On the A, this is non-contrast. This is B, it is with contrast, and very obvious. You can say multifocal necrosis is there. So when we talk about IV contrast, we all know that we need to give sedation. HRCT is very easy to perform, but your information will be half if you don't give contrast, as I've shown you to do contrasting CT scan with and without contrast. So in general, we require contrast. If you're thinking of malignancy, infection of the chest wall or the mediastinum, we want to delineate hilar, chest wall, and vascular margin. If you're thinking of some obstruction and you want to delineate vascular anatomy, like what Dr. Neetu showed us, aberrant vessel with pulmonary embolization, atriovenous malformation, of course we are going to perform angiography. Evaluation of empyema, if you want to do, though ultrasound is the best modality, but you should give contrast. I'm just again mentioning one case who came to us around a month back. He's a 9-year-old with staphylococcus sepsis with probable embolization, patient had DVT with bilateral pneumonia. I'm going to show you a wedge-shaped hypoechoic area. This is an ultrasound performed within 24 hours of patient presenting to us, right? You can see if this one B is a normal ultrasound, you can see this is the pleural line and this is the normal A line, but on A it is definitely a wedge-shaped opacity. So this wedge-shaped opacity actually was an embolization. So normally in embolization, what happens if you put in a Doppler, you will find not Doppler in the center, but the periphery you can make out venous and arterial projection inside, right? Now, in a normal patient, in a normal like consolidation, you will find this type of Doppler image. But in any given patient, if you're thinking of consolidation and you do an ultrasound, but you don't find Doppler image like this is a blackout image, or you can say non-echogenic or hypoechoic image within a Doppler image of that probable consolidation, either it is in FUB, but in this type of patient, it's not a wedge shape. Likely we may be dealing with necrotizing pneumonia. So ultrasound is an upcoming modality. If given to pulmonologists, it can help in preventing lot of unnecessary radiation, especially CT scan. Now, what are the indications where we actually don't need contrast? Look at this 8 months old. Unfortunately, I couldn't hide the face. Eyes, and 8 months old with means typical post adenovirus bronchiolitis obliterans. Everybody has been a lot of trouble this season with this type of patient, and patient not getting normal or fine for almost 6 months. On follow-up, every 3 months or every 4 month patient is having significant respiratory distress. In this type of patient, you go for CT, chest X-ray, and you don't get much information. In this type of patient, you may go for just simple HRCT or some cuts. That also is required, right? So you don't need to give contrast in these type of patients. In the patient, what Dr. Varinder Singh showed us, and typical sign of bronchiolitis obliterans, right? Now look at another child, a 12-year-old, again like a tuberculosis patient, a fever for 5 months with weight loss. And on the left side, the hilar looks little bit prominent, this lymph node looks prominent. So next choice, of course, till now we know that CT scan with contrast. On contrast, we could find that there is a necrosis, though it is little bit uniform, but there was definitely necrosis in some of the cuts. You go for gastric aspirate, you for bronchial lavage in this type of patient, but ultimately we have to go through the ABUS, what Dr. Chuk told us, that is your guided biopsy, right? So here the question arises, if you go for the CT scan and with contrast, what are the different type of characteristic lymph node expression gives you a different type of diseases? If you get a conglomerated lymph node, and typically peripheral rim enhancement, as you can see as a group of this lymph node, very likely with central low attenuation, likely this is an active disease and likely it may be tuberculosis, but though there can be many other diseases which can have little bit necrosis inside. But if you get homogeneously enhanced lymphadenopathy without calcification, there can be there can be many differential diagnoses. So if we conclude our, this present CT scan part, X-ray misses 15 to 20% of the lesions, we all know that. CT scan, if you find normal parenchyma, very likely your bronchial level lavage may miss your bulk which you want to detect. Character of necrosis gives you an idea about whether it's a Kikuchi, tuberculosis or malignancy. So this may be another 2 minutes I am going to take. Last modality, which I am already given you the glimpse, that is ultrasonography. So when we talk about chest X-ray, CT scan and ultrasonography, you cannot say which modality is better. You have to look at your patient, what the requirement of that patient is, okay? So what we need to see, is a chest wall, is it a parenchyma, is it a pleura, which part of lung or mediastinum I want to do. I am going to present the last case. This is a child who had necrotizing pneumonia on the right side, bronchopleural fistula. So almost for 12 days we found that there was persistence of pneumothorax. On 12th, 13th day we found that black color radiolucent cover is now, so the radio opaque is become actually radio opaque with chest tube inside and still drainage is coming. So it has become white, right? CT scan was performed, that didn't give us lot of information which we wanted. We want to look at why my tubes are not draining. What is actually happening inside that cavity where everything looks white which was black at 24 hours back. So you perform an ultrasound, you put in a probe here, and what you can see is almost full of loculi, lot of strands. So tube is not going to work. A normal pleural effusion is anechoic, or you can say black, alright? So this patient actually required thoracotomy, and look at the lot of strands came out and patient become normalized. So this is the beauty of ultrasound, and of course, sorry.
Time is over.
Yeah, I know, sir. I am switching to the last slide. So, last point about the CT scan and ultrasound. Ultrasound is better if you have got a loculations, if you want to demarcate. It is dynamic, no radiation, but CT scan still have role, especially if you have got a lot of tubes placed there, right? So if you have a lot of tubes and adhesives, then it's very difficult to perform ultrasonography. And if patient is obese, it's again very difficult and very challenging. But if you find a patient, if you find a patient with lot of necrotic pneumonia, and if you want to rule out what is happening inside the lung, simultaneously you want to look at the pleura, probably CT scan has got edge over the ultrasound. So I conclude my presentation. Before you decide the next modality, recertain about your decision, right? Discuss with radiologists, not just before going for any modality. After doing that CT scan, discuss with your radiologist, give him feedback. My clinical diagnosis is this one. Just don't consider them as just a paramedic and a non-clinical person. So that will give you much more better idea than actually you are having about the radiology. And regarding modality, again it depends on anatomical situation, image, whether you want to look at the inflammation, age group of that patient, sedation is required or not. Adults normally do CT scan very frequently, especially for elderly, but pediatric age group is going to last for say another 70 years. If you expose them for the radiation, it can be hazardous. And as I told you, ultrasound has got its own limitations. CT scan has got the major limitation in form of radiation, shifting the patient and giving sedation. And of course, MRI has got the motion artifact and takes a long time. Thank you very much for the patient hearing. Thank you.
Dr. Dhiren has differentiated the MRI, CT and ultrasound indication, and that is a nice presentation. And there is one question, Dr. Dhiren, why